Welcome to The Explainer. Today, we're tackling a critical medical mystery that honestly trips up both students and seasoned clinicians all the time. We're going to decode the kidney's primary filter and look at exactly what happens when things go wrong. It's the classic showdown, nephrotic versus nephritic syndrome. Okay, let's dive into this. Picture a classic clinical scenario, right? You've got a patient presenting with noticeable protein in their urine and significantly swollen ankles. So, what's the diagnosis? What's the immediate answer that jumps into almost everyone's head? It's a classic diagnostic trap. You see a couple of familiar symptoms, and the brain literally just wants to lock in an answer right then and there. But here is the warning. Do not jump straight to nephrotic syndrome. Assuming nephrotic right out of the gate just because you see protein and edema is a seriously dangerous pitfall. Why? Because getting this initial diagnosis wrong changes absolutely everything downstream. We're talking about the tests you order, the treatments you provide, the whole shebang. We really have to look deeper at what that glomerular filter is actually doing. Section 1. Nephrotic syndrome, the leaky filter. When we talk about nephrotic syndrome, we're really talking about massive proteinuria. The magic number, the threshold you absolutely need to remember here, is 3.5. This means the glomerular filter is passively leaking more than 3.5 grams of protein into the urine every single day. We're not talking about a minor drip here. It's a massive, passive leak of crucial proteins literally pouring out of the body. And because of that massive leak, you see a very specific cascade of clinical signs. The body is losing albumin, which leads to low albumin levels in the blood, and that in turn causes that profound edema, or swelling we talked about earlier. You'll also see high cholesterol. But I want you to look really closely at that last point. The urine is otherwise quiet. This is absolutely vital to understand. Aside from the protein, there's no blood and there are no cellular casts. The filter is just passively letting protein slip right through. So to give this a bit of clinical context, who actually gets this leaky filter? Well, the classic patient profiles really differ by age. In kids presenting with this massive, quiet protein leak, you're typically thinking of minimal change disease. But in adults, the picture completely shifts, and membranous nephropathy becomes your primary suspect. Section 2, nephritic syndrome, the inflamed filter. Now, what's really interesting about this next part is we're looking at the exact opposite picture, active destruction. The absolute hallmark of this pathway is the presence of red blood cell casts. What are these exactly? They are literally clumps of red blood cells that have gotten trapped and molded into the exact shape of the kidney tubules. When you see these guys under a microscope, it's a massive red flag. It indicates active bleeding and structural damage right within the kidney itself. The kidney isn't just leaking, it is angry. And this brings us to the core of the issue, the direct clinical signs of inflammation. We are no longer dealing with some passive leak. In nephritic syndrome, the proteinuria is milder, sure, but the filter is literally under attack. The severe inflammation causes the glomerular filter to swell up and clog. This active destruction severely restricts blood flow, which leads directly to hypertension as fluid backs up, and a rising creatinine level because waste simply cannot escape. The clinical signs of inflammation are driving this entire cascade. The kidney is actively inflamed and failing. So when you see this inflammatory, destructive nephritic picture, your differential diagnosis completely changes. The diseases causing this angry filter include things like IgA nephropathy, post-streptococcal glomerulonephritis, and lupus nephritis. These are conditions entirely driven by active, aggressive inflammation. Section 3. The memory anchor. Let's move to and see how this builds into one clear framework. And this brilliantly illustrates the one table that basically explains every glomerular disease by directly comparing the two syndromes side by side. Look at the urine status. You've got a quiet leak on one side versus an angry kidney with active bleeding on the other. Look at the proteinuria, massive versus milder. And most importantly, look at the core issue, a passive, leaky filter in nephrotic syndrome contrasted directly with the active inflammation and destruction you see in nephritic syndrome. So the crucial point is how you lock this into your memory forever. It's actually right in the spelling. In nephrotic, that O stands for protein, that massive passive leak. In nephritic, the I stands for inflammation and hematuria, the active, destructive, angry kidney. It's a super simple visual anchor, but it perfectly summarizes the fundamental difference in pathology. We've completely reframed how to look at these symptoms. So I'm going to leave you with this. The next time you see a patient with swollen ankles and protein, are you going to jump to conclusions? Or Or will you stop and check to see if that urine is quiet, or if there are active clinical signs of inflammation making it angry? Because answering that one simple question changes absolutely everything. Thanks for joining me on this explainer, and definitely keep that memory anchor in mind.